than 100 publications in GI. And his field of interest is GI physiology, functional GI disorders, GI infection, and hepatology. Welcome, Dr. Mayank. And he is going to speak on rational approach for constipation. Over to you, Dr. Mayank.
Thank you, sir. Thank you for the kind introduction. At the outset, I would like to thank the organizers for their kind invitation. The topic allotted to me today is constipation, a rational approach. This is the outline of my talk. To begin with, we must realize that constipation is a common problem in India. Based on the place where the studies were conducted and the criteria used for diagnosis, the prevalence of constipation in India ranges from 0.3 to 53%. It is found to be commoner in females because of slower transit, obstetric trauma, and harder stool forms. Constipation in Indians is different from the West because the stool frequency is higher, the stool forms are softer, and therefore the patient's perception that the patient feels that he is constipated becomes very important. As per this Bristol stool forms, type 1 and type 2 are taken as constipation forms in the West, whereas in India, type 1 to type 3 are regarded as constipation-associated stools. Now, causes of constipation can primarily be divided into primary causes and secondary causes. Now, we would be mainly focusing on the primary causes and not discussing the secondary causes that much. Constipation can broadly be classified into 6 different categories, and this is how we evaluate and treat constipation. First is constipation with alarm symptoms, functional constipation, IBSC, occasional constipation, dyssynergic defecation, and opioid-induced constipation. Constipation with red flags or alarm signs is any recent change in bowel habits associated with any of the following features: age above 45 years, family history of colon cancer or IBD, GI bleeding, anemia, weight loss, lump, fever, and significant weight loss. Functional constipation is the second subcategory, which is characterized as per Rome 4 criteria by 2 or more of the following, which should be present for more than 25% of the defecation: straining, lumpy or hard stools, sensation of incomplete evacuation, sensation of anorectal obstruction or blockage, manual maneuvers to facilitate passage of stools, and fewer than 3 spontaneous bowel movements per week. Functional constipation is further subclassified as normal transit, slow transit, and dyssynergic defecation. Normal transit constipation patients usually complain of incomplete evacuation with or without abdominal pain. Slow transit constipation patients have less than 3 stools per week, have hard pellet-like stools, and it is commoner in younger females. Dyssynergic defecation, we would take this a little later. To remember, 30% of patients who have refractory constipation have fecal evacuation disorders, 30% have slow transit constipation, and around 20% have overlap of both. Irritable bowel syndrome constipation is the third important subcategory of constipation. The important feature here is presence of recurrent abdominal pain, which is associated with constipation predominant stool types. It is important to remember that in India, patients usually do not complain of abdominal pain. They may report abdominal discomfort or bloating, but abdominal pain per se is less likely. So functional constipation is commoner in India than IBSC. Abdominal bloating or fullness is associated with IBSC. Majority of the patients with IBS will have psychological problems associated, which may include anxiety, depression, somatization, fibromyalgia. And if a patient is fulfilling IBS criteria, it does not exclude other disorders from being present. This is the Bristol stool form that we commonly use to determine whether a patient is constipated or he is having diarrhea. So type 1 and type 2 are usually taken as constipation in the West, whereas in India, type 1 to type 3 may be taken as constipation. And it is important to note that Bristol stool forms correlate very well with the colonic transit. The fourth subcategory that is of special interest to gastroenterologists is dyssynergic defecation. So here patients usually have functional constipation or IBSC, but they have associated features of dyssynergia, which is that they have a paradoxical increase in the anal sphincter pressure on attempted defecation as tested by anorectal manometry. They have less than 20% relaxation of the resting anal sphincter pressures on attempted defecation, and they have inadequate propulsive force. In addition, patients have an abnormal balloon expulsion test or have abnormal MR or barium defecography. Opioid-induced constipation has features similar to functional constipation, but it is characterized by development of symptoms at the initiation, changing or increasing of opioid dose. The last subcategory that we are discussing is occasional constipation. This is a new type of constipation that has been described recently. Here patients have intermittent or occasional symptomatic alteration in bowel habits. They do not have alarm features and do not fulfill criteria of functional constipation, IBS-C or fecal evacuation disorders. We did a study at our center where we found that the prevalence of occasional constipation among patients reporting to OPD is nearly 40%. These patients are predominantly younger. There is an equal sex distribution. Patients report a history of reduced fluid or fiber intake, recent travel, and use of drugs, leading to occasional constipation. Nearly 50% of these patients use over-the-counter medications for treatment, and 1/10 even use enemas. And majority of the patients do not have recurrence of symptoms. However, 25% may report recurrence of symptoms. So how do we evaluate a patient with chronic constipation? First and foremost is a good history and clinical examination. These two are of paramount importance whenever we are seeing a patient of chronic constipation. History should include onset duration of constipation, the relationship with meals and bowel movements, any surgical history, history of addictions like tobacco, alcohol, smoking, comorbid diseases, and associated FGIDs. Family history of colon cancer and IBD should be taken into account. It is very important to take history of drugs. Drugs like anticholinergic drugs, antipsychotics, opioids, antihypertensives, anti-diabetic drugs, lipid-lowering agents, anticonvulsants, simple drugs like iron, calcium, and aluminum antacids can also cause constipation. One should inquire regarding red flags. A dietary history is important, where we should stress on the fluid and fiber intake of the patient. Lifestyle, how much do they exercise? What is the timing of defecation? Are there any distractions while they are trying to defecate? Type of toilet used, whether it is Indian or Western, is of great importance. Maneuvers to facilitate defecation should be asked. Obstetric history in females is important. And in case the patient is fulfilling criteria of IBS, it is very important to look for associated psychological issues and sleep. It is well documented that Indian toilet is more physiological than Western because it leads to better relaxation of the puborectalis and widening of the rectoanal angle. It is faster, easier, and leads to more complete evacuation. It prevents excessive straining and protects the pelvic nerves from becoming damaged. In examination, a good detailed examination is required. Most important is digital rectal examination. All patients with chronic constipation should undergo a good digital examination. Even a good digital examination has a very good sensitivity and specificity in diagnosing dyssynergic defecation. So how a PR examination needs to be done? Patient should be put in left lateral position. We should inspect the perineum, look for any skin tags, hemorrhoids, fissure, or prolapse. We should check the perineal sensation and inocutaneous reflex. Digital palpation should be done for assessing the resting tone, and then we should ask the patient to squeeze and look for the squeeze pressures. And then we should ask the patient to bear down or behave as if they are passing motions. While testing this, we should place our left hand over the anterior abdominal wall of the patient to appreciate the push effort of the abdominal muscle. We should look for the relaxation or contraction of the anal sphincter and perineal descent. Once we have done a good examination, we proceed with the diagnostic test. All patients of constipation should have these baseline investigations. If fecal occult blood test is positive, patient further needs imaging investigations and endoscopy. Colonoscopy is usually indicated only if patient has alarm features, fecal occult blood is positive, or there is a family history of colon cancer. Once we have diagnosed that the patient has chronic constipation and there are no alarm features and stool for occult blood is negative, then these patients can safely be started on laxatives. If patient has bloating, then it is better to administer polyethylene glycol or milk of magnesia. If patients do not have bloating, then fiber diet can be initiated depending on the fiber intake of the patients, and other laxatives like lactulose and lactitol can be initiated. In case patient has alarm features and stool for occult blood is positive, colonoscopy and other investigations are required. If patients do not respond to this or have refractory constipation, we need to subject the patients to physiological tests like colonic transit study, anorectal manometry with balloon expulsion, and difficography. Colonic transit study is a simple test in which 20 radio-opaque markers are given at 0, 12, and 24 hours, and radiographs are taken at 36 and 60 hours. If more than 30 markers are retained at 36 hours and more than 14 markers at 60 hours, the test is considered to be abnormal. Other tests like anorectal manometry, MR or barium difficography, and balloon expulsion, which is done along with anorectal manometry, help in better diagnosis and help to confirm the diagnosis of dyssynergic defecation. These criteria I have already shown earlier. These are mandatory to be fulfilled to diagnose a patient as dyssynergic defecation. Now the treatment depends on the type of constipation, as we have discussed earlier. If patient has dyssynergic defecation, biofeedback treatment is required. If slow transit constipation, then prucalopride or stimulant laxatives are required. Surgery is indicated only if patients have severe slow transit constipation, very large rectoceles, or adult onset Hirschsprung disease. Once we have done the physiological tests, we can classify patients into 4 groups. Those having all physiological tests normal, they usually have normal transit or IBSC, and these are treated with secretagogues or laxatives. Patients who have abnormal colonic transit study, these patients usually have slow transit constipation and are treated with prokinetics or stimulant laxatives. Patients who are having abnormalities in anorectal manometry, balloon expulsion test or difficography have fecal evacuation disorder or dyssynergic defecation, and these are treated with biofeedback. And if patients have features of both, that is slow transit and fecal evacuation disorders, then they require treatment for both. There is a new concept that in certain patients who have slow transit constipation and who are not responding to prucalopride or stimulant laxatives, research has found that these patients may have high methane levels in their gut. There is increased number of a bacteria known as Methanobrevibacter smithii, which increases the severity of constipation, and in this distinct subset of patients, actually rifaximin might be useful as it improves colonic transit. There are several drugs that are available in India for treatment of constipation. However, we do not have the time to discuss all in detail. So I'll be just covering some important situations and how we should manage them. So when we have a patient with slow transit constipation, always rule out secondary causes of constipation. Lifestyle improvement by diet, fluid, exercise, and using an Indian seat or a Western seat with a footstool is important. We should screen these patients if they are not responding for fecal evacuation disorders. Stimulant laxatives and enterokinetics like prucalopride are the first line of choice. And if there is no response, then we should look for high methane production. In IBSC, we should not give stimulant laxatives because they increase pain. If bloating is present, we should not give fiber, lactulose, or lactitol. Antispasmodics like otilonium bromide, prinavarium can be given for pain in case it is severe. SSRIs may be given because they do not increase the risk of constipation but do not give tricyclic antidepressants. Secretagogues may be tried in some patients but do not work in slow transit constipation, and it is very important to treat psychological issues with appropriate neuromodulator drugs and psychiatric consultation. Biofeedback therapy is basically a neuromuscular training with visual, audio, and verbal feedback that is done by gastroenterologists and physiotherapists in the West. Now it improves symptoms and anorectal manometry parameters. As it is time consuming, it has a poor compliance in Indian setting. So we came up with an innovative behavior therapy intervention where we did one session of biofeedback for our patients in the hospital and followed it up with diaphragmatic breathing exercises and pelvic relaxation exercises at home. Our preliminary data of 35 patients shows encouraging results, and maybe this may be the way to move forward. Pregnancy is another important situation where we see constipation. It is important to remember that it is multifactorial. Diagnostic tests are best undertaken after delivery. Treatment is basically with dietary counseling and medications like lactulose and polyethylene glycol. In case patient has developed hemorrhoids and anal fissure, they have to be managed conservatively, and only if thrombosed piles are extremely painful, they need to be treated surgically. So this gives us an overview of the different subtypes of constipation and different management strategies. All these 6 subtypes, whenever a patient comes to us, we should try and classify the patients and try to fit them into these 6 broad categories. There might be an overlap. Based on the broad category, select your diagnostic aids and select your management. So to conclude, constipation is common in India. It is commoner in females and commoner in functional constipation is commoner. We should always rule out secondary causes of constipation, look out for red flags. We should perform a digital rectal examination. It's a worthwhile test on the bedside, it gives us a wealth of information. We should subtype patients based on their symptoms, baseline investigations and physiological tests into different subgroups, and then tailor our management according to the constipation subtype. And biofeedback is definitely useful for dyssynergic defecation and needs to be practiced. Thank you.
Thank you, sir. You covered the topic very well. I think you covered every aspect. Even if there is some question, you can ask for audience.
With me, Dr. Vinod is here. He is the master of anorectal manometry as well as biofeed mechanism. I think we should have his points regarding this anorectal manometry.
As Dr. Mayank has already said, anorectal manometry, yes, it's a very useful test for the diagnosis of basically dyssynergia. And biofeedback is also very useful as the point of view for dyssynergic defecations. But the compliance for the biofeedback from the patients is very poor because it requires multiple settings. Single setting is not useful. It basically requires minimum 5 to 10 settings to get a response from the patient. But in our Indian scenario, the patient wants absolutely relief within 1 or 2 settings. He is not ready to go for further biofeedback training. My question to you, is there any relation of age with biofeedback?
Yes, sir. Definitely in extremes of age, it is very difficult for patients to understand what we are trying to explain by biofeedback and to follow it up, especially in older patients because they have comorbid diseases like diabetes, neurological problems, hypertension. They are on multiple medications. So there may be other causes of constipation apart from dyssynergic defecation. Regarding the first point that you raised, I also agree, and this has been our observation, that majority of our patients drop out of biofeedback program. That is why we came up with this innovative approach where we have done biofeedback just once in the hospital, and then we taught the patient diaphragmatic breathing exercises and pelvic relaxation exercises, which they were doing daily at home. And we followed up the patients using WhatsApp or Zoom calls. And over a period of 3 months, we realized that majority of the patients who were doing their diaphragmatic breathing exercises, pelvic relaxation exercises very well at home, they responded in terms of symptoms. We did not do a repeat anorectal manometry to demonstrate that there was improvement in anorectal manometry parameters, but definitely there was an improvement in symptoms. So basically we are trying to treat the patient's symptoms, and that is what we have recently submitted in Indian Journal of Gastro, and it is accepted. So I think that might be the way forward for us, because we have to design our biofeedback programs which are tailored according to the patient needs. Majority of the patients who come to us are from villages. They cannot come every day for a biofeedback setting. So we usually give them just one session of 1.5 hours, teach them properly, and then explain diaphragmatic breathing exercises, pelvic floor relaxation exercises, which they have to do at home for at least 20 to 30 minutes every day. That is what we have found to be helpful in our setting.
Do you give all the same kind of exercises and same kind of biofeedback training to each and every patient of dyssynergia?
No, sir. It has to be tailored according to the patient's subtype of dyssynergia.
Yeah.
So that is why we take around 1 hour for each patient when we explain the type of defect that is present, how do we need to deal with it, what are the exercises that need to be done. That has to be individualized to each and every patient. Diaphragmatic breathing exercises are definitely useful for majority of the patients of functional GI disorders, including aerophagia, rumination, bloating, constipation. So majority of our patients of other functional GI disorders are also on diaphragmatic breathing exercises. These are very useful exercises, and these can be explained, and patients can follow them up at home very easily. So in case patients are having functional GI disorders, diaphragmatic breathing exercises are really helpful.
Any other question from the audience?